Hey guys, welcome back to the FOAMfrat podcast. Tyler and Sam here, and we're going to talk about Bougie, the Bougie placement, using Bougie for intubation. Sam did a blog, and he talked about all the different utilizations, the different grips, some of the evidence to support Bougie use. What was your inspiration behind that, Sam?
So just messing around pretty much. So Jim DeCanto came over, and he had a bougie idea that he was working with that was different. Something I don't even know if he's went to social media with it yet, so I won't say anything about his project. But we were just messing around with stuff, and I started holding the bougie in the tube a different way, and it made me really start playing around with some of the different styles and thinking about the pros and cons of using each one. So I was like, that'd be a good blog. I don't want to, dig up pretty much. I didn't go like all the way into the research. So I only went to the 80s. I didn't want to go any further back than that. So it was like 80s through today. I feel like I'm announcing the playlist 80s through today on FOAMfrat Radio. But went through all that literature and put some of the relevant pictures up and stuff like that, and then did some drawings of the different grips. And so I don't know, the literature is so good on it, but I think that some people are still on the fence, but I was like, why don't I just highlight this stuff, and then we can look at some cool bougie views and stuff.
Yeah, there's definitely some diehard stylet fans. I know in paramedic school, the Bougie was framed as a rescue device, right? So like you tried to intubate, you didn't get it. Maybe you tried something else, it didn't work. I was like, all right, now I got to use the Bougie. And that never made sense to me, because anytime you're looking at somebody putting like in a central line or like, ECMO cannulation or anything, they're putting in a guide wire first, and then they're putting the cannula over that. And that's really because it's easier to get that guide wire in than it is to get the actual cannula in or get the ET tube in. So that Seldinger technique just makes sense that you would do that with intubation, where you'd put the Bougie in and then you could put the ET tube once you already have that track outlined. And I know you had a similar situation when you were going through your clinicals where the tube actually obstructed your view.
Yeah, that was what turned me on to the Bougie in the first place. So I outlined the stories in the blog. You guys will have to check it out. But yeah, I had a horrible first time experience with my OR experience. I sat in a waiting room. I was only allowed to go back for endotracheal tubes. And seriously, 7.5 out of 8 hours I was there. I was in the waiting room just reading my book, and I finally got a chance to go back. And I missed the tube. The anesthesiologist, I really wanted to use a Mac blade. I was more comfortable. I even had trouble with Miller blades in simulation. I really didn't like them. And they made me use a Miller blade, and then I had this honking tube, and it was just all wrong. I flailed around in the airway, thought I saw something, go to put the tube in, view completely obstructed. I went straight down the channel of the tube, couldn't see anything. That was quickly over. And then I didn't get the tube. And then the anesthesiologist did it, with practically their eyes closed. And so a clinical shift wasted. And then I did a similar thing, my first field intubation. I didn't get that either. I was working with one of those black and white King Visions and obstructed my view, dipped the camera in gunk, did all the wrong things. And it wasn't until I went back for more operating room clinicals that somebody showed me about positioning, progressive laryngoscopy, landmarks. And then the biggest thing, well, maybe not the biggest thing, but a huge part of it was bougies. And I was, I explained to him what happened the first time, because I felt like I needed to get it off my chest and tell him about it. Like, all right, here's what happened last time. Like, can you help me? And they're like, well, that's a common thing if you got a small, opening, small view. Like, let me show you something over here. It's called a bougie. I'd never seen one before. And I'm like, so you just put this in, and then it was like a light bulb clicked off. Like, I can just put this thing in, and then the tube will go over it. Like, this is crazy, So that's what I was turned on to it since then, where that helped me a lot. It helped me a lot.
Yeah, I remember when we got these at Lifestar, and we were super excited with them. We had the co-pilot ones. They were the orange, right? The little orange ones.
Yeah, the co-pilot VL was orange. I have one.
Do you? Yeah, and we got them, and I remember thinking like, oh, we got to keep these things curled up because you want to have that little anterior bend, right? Because everybody's always saying that the airway is anterior. So, if you got that little bend in it. But then what would happen is like people would store them, and then when you would pull it out, the end would be like all cattywampus. It'd be twisted to this side. And so then we were like, oh, we got to keep them, like, let's keep them stored as straight as possible. But then there's
It being crooked is the worst. When it's bent off to either the right or the left, like this
oh
one is right
yeah.
now, you can see, like, that's the worst. If it gets crooked like that, that's difficult to deal to deal with.
Yeah, I've also seen like when somebody's using a stylet, they're trying to like intubate and they can't get it, and then they pull it out and it looks like a crazy straw, like because
That
it's
we gotta come up with a name for that, like a term for that when it goes in and it comes out like that. Like, that's because that is such a funny thing in simulation, not in person, but in simulation when it goes in looking like straight to cuff, and you're like real nice, and then it comes out, yeah, it looks like a bendy straw from like McDonald's or something. So funny.
yeah, and then some of the bougies actually come like the what is it, the pocket bougie and the bougie to
And the
go.
bougie to go.
They come with that bend already in it. I don't think those are as long. Maybe they are now, but that pocket bougie one was pretty popular for a
Mhm.
while. I know a lot of people they liked it because they could keep it in their flight suit. And yeah, you had the ability to use that.
It's easy to keep in any airway bag.
Yeah, but you know what's funny? Some people go as extreme as like putting their bougie in like a PVC pipe in the ambulance to keep it
Mhm.
straight. Those are some hardcore laryngoscopists that want to make sure that it's very straight. And it makes sense because you want to be the one to put that little bit of a bend in it
Mhm.
after you observe the airway. If you're just assuming that they're going to be ridiculously anterior, likely if they're that anterior, your positioning is just awful. And
Yeah.
then two, you want to be able to put that little bit of a curve in it. And that way it's not bending the wrong way when you actually need to use it. And
Mhm.
even with like with VL, like the channel devices. Remember when we got the King Vision at Lifestar?
Yeah.
We would tell them to put the preload the bougie into the tube, and
Mhm.
then get your view, push the bougie down first so you can watch it
Mhm.
actually go into the glottic opening, and then you railroad that tube over the bougie. So even if you're using like a channel device, you still can use the bougie with that.
Yeah, and, we had a really interesting experience with the Vivid track when we tested that out too. I don't know, probably not too many people are familiar with that one, but I mentioned it in the blog because it was such a weird thing. The Vivid track is a disposable, essentially, it's kind of the same form factor as like a King Vision, except it's a USB plug-in to like a laptop or a tablet or whatever. And, with that one, it shoots so anterior that if you put the coude tip first, it actually usually ends up in the vallecula.
Yeah.
So, and that, which is a super weird problem to have, right? And so you can actually reverse the bougie in that one and put the straight end out front, and then it usually ends up. But you do lose tactile feedback with that, but you generally don't need it if you're using like a channel device like that. So that was one interesting thing. But yeah, I think they're super cool with channel devices like King Vision, or I'm trying to think of some other ones, but I think that's a super cool way to do it. And with most of them, you have to have the tube in there and then the bougie, like tube and bougie in there, like you mentioned, because otherwise, without that little thickness of the tube in there, it kind of shoots down. And so
Yeah.
usually it's much easier if you have the tube preloaded.
Yeah, the hyper angulated blades, if you're going to use the bougie, they got to be channeled. I don't know if you've ever seen somebody try to use a hyper angulated blade without a channel. You remember how you could get the channeled or
Mhm.
unchanneled, because your view is really, really good because you're
Mhm.
going down and you're peeking around the corner. But then when
Mhm.
you go to put the bougie in, every single time it wants to drop posterior. And so
Yeah.
that's why with like the glide scope, you'll see them use the rigid stylet because they can go in like,
Mhm.
you remember DeCanto teaching us what was
Slot
it, the slot machine
slot
technique?
machine.
Yeah, going in above and then pulling it back, and it's got that nice curvature in it.
Yeah,
But
he always had a lot of hand motion, but very little elbow motion. I remember that. It was like or what? No, the tip of it would barely move, but your arm went through a lot. It was like the tip of the tube was barely moving, but you were really like angling around it to angle it up in there with those hyperangular or those hyperangulated VL style or rigid stylets.
in traditionally, like the bougie use is a two-person technique. So what you would
Mhm.
do is you would go in and you'd find it, you put the bougie in, somebody would come over and they would take the tube and they would put it
Mhm.
over top of the bougie, put it down, grab a hold of the bougie, and then slide the ET tube, down. And that dance where somebody's trying to put it on top and you're trying to hold it.
Dude, it's like this when somebody's like chasing that thing around is one of the funniest.
And so I know a lot of people have moved towards preloading their bougie and
Mhm.
making that a one-person thing, so you don't have
Mhm.
to tie up somebody else. And when we jump in the back of an ambulance, we're doing like an intercept. Typically, the airway person's sitting up at the head, and then like my partner will be down here, like drawing up meds, like on the bench seat or doing an ultrasound or something. And so it's nice just to know that you can just do that all yourself. There's still, I know a lot of people that like to do the two-person thing, but
Mhm.
there is a lot more attention now going towards the preloaded bougie. And so
Yeah.
you outlined a couple. You did a really good job drawing these too in your blog. And I thought we could start off with this first one, which is just like the tension kind of hang loose, where you're just holding tension on that bougie through the ET tube. So it's already preloaded, and now you're just holding that tension, so that way when you advance it, it's not sliding out the top of that endotracheal tube.
Yeah, that's one of those things that you really got to watch with any kind of because I feel like what most people will do the first time they pick up a bougie is they'll just take it, hold the tube right in the middle, and then they have a bunch of bougie hanging out the front end, which is the idea. Obviously you want a bunch of bougie out of the front end, but then once you start running into stuff in the airway, it starts going out the back end of the tube. And
Yeah.
then all of a sudden you realize that there's absolutely no bougie out in the front of your tube, which is completely, you might as well have you essentially have like a very useless stylet at that point.
Right.
And so you definitely want to have some kind of, well, however you end up accomplishing it, you want some kind of torque on that bougie so that it doesn't advance back into the tube, because you'll lose whatever's out front. But I think that's a really simple one. Some people, I didn't mention in the blog, some people criticize it because you're touching the cuff.
Mm-hmm.
Now, I guess maybe you don't have to hold. I don't know, a cuff, or if you're holding the tip of the tube, it's kind of the same problem. If you had something on there that's ending up pretty deep into the airway, so just something to be mindful of if you do use any of these grips. Really, if you can avoid touching the cuff or anything that's going to be on the other side of the glottic opening, that would be preferable for
Yeah,
sure,
put
and
fresh
not
gloves
letting it
on.
touch too much on the way in. What's that?
Put fresh gloves on too. If you got
Yeah.
somebody you just got in from a field or they're bloody or
Mhm.
stuff, don't go touching that stuff.
Yeah, or just put another set on if you can't take them off and put them back on. That's another funny thing. I'm thinking of all kinds of like awkward thing. We should do a podcast on awkward things on scene when somebody's really, you got to do
Sweaty.
a skill, and so somebody wants a fresh set of gloves, so they take the first set off. Hey, can you come over here and help me? And they're like, "Yep." And they can't get it on over the sweaty hands, and so they're
This
trying to
fingers like loose and just dangling.
Mhm. Just put another set on. Like
We've gotten
right
the
over
habit
the
of
top.
doing that because of COVID. We double glove, so like
Mhm.
I kind of just got in the habit of putting two pairs on and then taking that
Yeah.
other pair off. That's probably a really good idea for this. Like if you're going to be intubating, have two pairs of gloves on, and then when you actually got to hold the tube, pull off the other set.
Yeah, that's
Um,
not a bad idea.
that
So the other
issue.
one was
Oh, go
just
ahead.
naked bougie, or I don't know what you call it. I suppose we should just call it Seldinger technique. Is that
Yeah.
maybe that's what it's really called? So that one, yeah, I mean, a lot of people are fans of that one, where you go in with just the bougie. I didn't highlight that one too much in the blog because I mean, everybody knows how to. Obviously, you just aim the bougie at it, so I didn't feel like it deserved a picture. But one thing you do want to watch out with that, I put a few recommendations into the blog about if you're gonna do bougie only and then do the whole two-person technique, or maybe you're good enough to hold the bougie with the laryngoscope hand to hold it steady and then put it on. So maybe you can do it by yourself. I don't know. But just a few things to think about. Keep the blade in there because that softens the angle, and then you can actually watch it and troubleshoot it at the glottic opening. That's important. Um, and then make sure, at least if you can, position them to lessen the angle again. And I thought that was another one that I put in the blog. Lessen the angle. Oh, and then the reason that you want to watch it at the glottic opening is because you don't want to force it, because there's some troubleshooting stuff that we'll talk about at the end, like training and troubleshooting stuff, but it can definitely get caught up in a couple different locations. And so you want to be careful of that. So if you do choose to use this kind of bougie only technique, definitely know the troubleshooting. Don't turn it into a blind. Don't turn it into a blind skill.
Intubation. Yeah.
Yeah, I think that's way better, just to keep as much of the laryngoscope in there as you can, instead of what most people do is take the laryngoscope out and then they violently shove that thing into a right angle and slam it past the glottic opening. I don't think that that's good. I wouldn't want to see what that actually looks like down at the airway.
Yeah, no, I agree. That tension that you got to hold on the bougie, if you're doing it where you preload it in the one we just
Mhm.
showed, some people rather do the Kiwi technique and just put a little bit of a bend in it. And so the Kiwi or the pistol grip looks like this. And essentially what you're doing is, instead of having to hold that tension on the just the bougie through that, you're putting a little curve in it, and that gets rid of that awkward top weight that you have of it moving around on you while you're trying to place it. So the Kiwi technique is where you just put a bend in it and then you hold that bend. Sam, you're doing that right now. You're not.
Yeah, I mean, you can. I'm right behind the cuff right here, and I always tell people to hold it like they would be writing something, like a pen or a pencil, and then just taking this end and curling it behind their thumb over there like this, and you can kind of stay off the cuff like that. But this is surprisingly hard to teach people when you have it like this, and just like watching the other side of my hand like that, like tucking it behind there. It like that is very natural to you and I because we've played around with that so much. But if you just try to describe it to a person for the first time, or if you show it to them for the first time, I feel like learners actually, it doesn't usually click very fast with them. And the other thing with that is like you have to maintain that grip, otherwise it's not going to work very well. So that's one thing. If you are going to use that grip and you're just looking for something real quick, somebody hands you a tube and you're going to do that. Just be sure that that hand doesn't have to do anything else anytime soon, because you're kind of stuck in that grip.
Dude, I can't help but try to get my shoulders to match up with yours on this split screen here.
Right in there.
I keep moving it around. All right, let's talk about the D grip. This is where you actually go in through the tip of the ET tube. And I'll show you this picture. Sam, you want to demonstrate it real quick? You're going to go through the end and then out the Murphy's eye.
Yeah, I'll try to get this a little bit closer to the camera. So I don't have a ton. You can, I mean, I guess you can cinch it up later, but you can see that Murphy's eye right there, which a lot of people were asking what the Murphy's eye is for. That Murphy eye is just to allow ventilation. So if the end of the endotracheal tube gets up against the wall of the trachea, or it gets a goober in it or a blood clot or whatever, that at least there's an auxiliary port somewhere around there. So it's just a safety thing. But what you do in this case is you go in from the end, and it's sometimes helpful if you hold it back. So if you guys can see, there's like a big lip right there. And once that's held back, it's pretty easy to get that in there. And then I almost pretend it's like a zip tie to like pull it a little bit. And then I've got a bunch on the end here, and you can, it's pretty nice. I mean, it's locked in place, and that, I think the best, like if you were really good at it, you just have a bit in the end there so that you can flick it off pretty easily. So if it just went into the airway, you know, I can pretty easily just like pop that out of there and then advance the tube.
Yeah. And once that bougie is in and it's in far enough, I don't even bother holding the bougie at the top as I'm putting, because it's not like you're going to lose the bougie down the trachea, you know?
No.
And I notice some people will be like, oh, you got to hold it still. It's like, excuse me. Once you put it in and that bougie is in far enough, then you can just feed the tube down and then pull the bougie out. You don't got to worry about holding it while you do that.
Yeah, that's going to get hold up sign before you're going to lose the bougie, most likely. Oh, what are these strange messages that are showing up?
Oh, what?
We have a new streaming platform, by the way, guys.
That's weird. I don't know what that was.
Except for when we screwed up this recording yesterday. That wasn't exactly the ball when we were playing with it. But yeah, what's our next one? We did Kiwi, D-grip,
the smoke and a drink.
Preloaded. Ah, yeah. So this is what I was playing with. This is what got me started on this whole thing with doing this bougie blog. Was that's how I was holding that bougie when Jim and I were messing around with these. And I got to thinking, I like that a lot, because I'll just kind of show you with, I'm going to put this syringe back on here. But the thing I like about this is that it really leaves that hand open to do anything else that is required up there at the airway. So when I have this, you know, I kind of just hold this syringe here, and then it's really easy. I just kind of grab it wherever, and it's really easy to maneuver like that. And you can get this little guy up in the you can do a little anterior turn right there. But the cool thing is that what you can do is you can take this and put it really far into your hand, like really into your palm like that. And this is essentially like having, like, I could type a report like this. Like I can pretty much do anything I need to with this hand over here. This is just staying here. Like essentially I'm not doing anything, and I could completely like even do an airway maneuver like this if I needed to, or squeeze a bag valve mask with this in my hand. It looked kind of ridiculous, but it is like a very free hand like this.
Like, hey, when you're done doing that report, Sam, can you intubate the patient when you're done typing
Yeah.
up that chart?
Hang on, guys. I just typed in those induction medications that you give. I'll be right over there in a second. I've got it all ready with my clean gloves and my bougie in hand. Yeah. What dose of Vec was that? I just wanted to write that down real quick.
The smoke and a drink, man. I'm looking at it again. I like it. I think it
Yeah.
makes sense. I like that you're controlling the syringe. Sometimes that syringe gets knocked off, and then you get it in, and you're like, guys, give me a syringe. And then somebody gives you the one that they use to drop the RSI medications. And like,
yeah. Or you look back and it's somebody stepped on it or something and it's crushed and it's cracked or something stupid like that. Yeah. So I think those are all the grips. And I've got those pictures are in the blog and stuff. If you guys want to check those out, I did a close up of that D grip as well with it going through the Murphy's eye. If you guys wanted to take a closer look at that, but the other thing I wanted to hit on was just training with these things. So kind of like I was just mentioning, where I have this setup, and I'm supposed to place this endotracheal tube, and when I'm training for that, I think the tendency is to have a mannequin on the table, and then you have laryngoscope in one hand, and you have this bougie and this tube in the other. And it's cool to practice like that if you're just doing technique stuff. But I think when you're finding a grip that works for you and a technique that you actually want to do in the field, I think the best thing to do is take that from an occupied hand point of view, because that's like the most kind of discoordinated or uncoordinated you're going to be during that call. So if it's your job, a good position to practice from would be you're stuck in a two-hand seal. You're stuck holding this mask seal, and maybe you're coordinating people on scene, and they're drawing up your induction medications over there, and they're like, yep, okay, that looks good, go ahead. Okay, in a second, you're going to hand me this tube and the laryngoscope. And from this position, you're really starting fresh. It's not like you've had this coordinated hand position with the bougie where you're perfectly set up to go. Like, how long does it actually take you to get that coordinated in your hand, and to, if you're going to use like a 2-finger technique to open the mouth, or like, how exactly are you going to do that with the bougie in your hand? Can you transition easily? I think that's where the disconnect comes from with a lot of people. With preloaded stuff, it's super easy because it's all just one unit. Somebody hands it to you. Like, that's very easy. But if you're using one of these preloaded techniques and nobody's very familiar with them on scene, it might throw you off a little bit if you've only practiced like going straight in without being preoccupied first. So I think that's a really important training thing to do, is put yourself in an uncomfortable situation at the outset.
Yeah, the other thing I notice with the bougie is the bougie will go in, but sometimes people have a hard time getting the tube to go over it, right? And so it gets hung up in the arytenoids. Or the other thing that can happen is you go in and the bougie is not going down the trachea. It's hitting the anterior like cricoid membrane up here as you're going in. And if that happens, you really just gotta turn that bougie around. And I've seen that more often than not, where somebody will go in, and even when we do like our cadaver labs, some of those, you go in and you're like, I cannot get the bougie to go down the trachea. It's like going in and hitting the anterior cricoid. And so you just want to turn that around so that way it goes downwards. And when we do the cadaver lab, everybody can intubate those things, like but we try to mimic and duplicate some of the problems that you see with the bougie. And I would say, like, when you got your airway mannequin, instead of just doing straightforward intubations, like, use a larger endotracheal tube, because it's more likely to get hung up on the arytenoids. And then you do that counterclockwise turn. What's interesting is a lot of people don't know why you go counterclockwise with the turn. They're just like, I was always taught counterclockwise. You have the tube around that you can show it.
Yeah. So I'll see how good of a view we can get with this. So this is how the endotracheal tube and the bougie are entering things. And so essentially where that, if you guys can see the angle of that,
get it a little closer.
If you guys can see the angle of this, let me get my face out of the way. Maybe there it is. So this angle right here, that bevel right there, as you're going into the airway, that's on the patient's lower right-hand side, and it gets caught up. And so what you have to do is you have to turn the bevel down. So essentially I'll just do this kind of with my hands. So if it gets caught up like this on the right, what you're doing is you're turning that bevel down so it glides over the interarytenoid notch. And so you want the bevel facing down. So you withdraw a little bit, bevel down, and then it comes up. Let's see, can you get it to focus? There it is. Yeah, so that bevel gets caught lower right. Yep, there we go. So he's like simulating it going over the interaretinoid notch. Man, autofocus is a real bear, huh?
Dude, hold on.
There we go. Yep, there we go. Sliding over the interaretinoid notch. Very, very good visuals. And so that's one thing that can happen. So you mentioned actually one other one that I didn't think of. So two things can happen. So that's how you get it past the initial. That's usually the first hang up because the bevel is always left facing. Just turn bevel down. You go over the interaretinoid notch. That's super common. So that's like the first one you want to know. And then the second one, I guess it's kind of like one. The second one you want to know is about what Tyler was talking about, where the tube and the bougie can get hung up on the anterior tracheal wall. And so if bevel is down coming over that interaretinoid notch, you now have like the pointiest part of that, not only bougie, but tube sticking into that tracheal wall. And so now if you get stuck after the glottic opening, you turn bevel up because then that softens it against the anterior tracheal wall. And so with the bougie, that would apply the exact same principle and motion would apply to the coude tip, and where you can turn it down and make it go down the trachea. And it's something that Jim taught me actually was that big movements up top equal little movements below. When you're turning that bougie or you're turning that tube, you're usually manipulating it much more on the top, a further distance, a farther rotation or whatever, than you are than what you would think, I guess, to get a small movement at the bottom, because there is some give, I guess, in between where you're manipulating it and where you're seeing the effect.
Yeah, I thought I had a good video. I'm looking on my computer right now of that in a mannequin where we're trying to duplicate that. I don't see it now. I have to look for it. But
if you find it, we'll throw it at the end of the podcast or something.
Yeah, I thought that'd be cool to see that. But trying to like duplicate or replicate those issues that you have in the field on the mannequin is huge. And one of the ways you can do that is by just using a larger endotracheal tube. You know, when you do simulation, they'll be like, oh, this guy takes a 7. You know, if you use a bigger one, then
10.
you start, what's that?
Go 10.
Yeah, or 13, you know, just get to see how big you can get it. But or don't like lube up the airway. And have you ever done that? You can't get the tube.
That'll be really good. I'm sure that
it's great for the mannequin.
Sigma is just rolling their eyes right now. Yeah, just destroy that, man. You just want to get that thing as caught up as you possibly can. Real good for the mannequin.
Dude, those 7 Sigma mannequins are crazy. Like,
yeah,
it's not, and they're only getting better. I was talking to, I had breakfast with Troy the other day. We went and got coffee, and we were talking about like the jaw opening. Because that's one of the things that I've noticed is like even some patients who are paralyzed, like they just got small mouths, right? And it's just like you can't get their jaw open very much. And so I was like, it'd be cool if you could change the jaw tension to where like you have to go in and, you know, maybe that's a situation where you use a hyperangulated blade, like the Carl Storrs has the D blade where it's hyperangulated and use it with the rigid stylet. And what I've noticed with like those rigid stylets is you'll go in, you'll get the tube past the like the glottic opening, but then like you can't advance it down because there's that strong hook at the end of the rigid stylet. So you gotta, once you're in, pop that stylet out and pull it out of the tube a little bit. So you got some of that tube that doesn't have the stylet in it, and then slowly feed that down as well.
Yeah, that's another one too that you can do trying to think, a counter, or no, you can do a clockwise turn with, so you can go out the other way to turn the bevel around so that you can go down the trachea a little bit easier. I've seen people do that with hyperangulated as well. Like doing what you were saying, popping the stylet, advancing a little bit, popping the stylet, advancing a little bit. But I've also seen them do turns with that to get that bevel, to get the bevel facing the anterior tracheal wall. So it's kind of the same thing as before, that obtuse angle where it gets to go down. So I'm just trying to think, yeah, that would be correct. So when this was stuck, we did a counterclockwise turn to get it over the interaretinoid notch, but with those hyperangulated blades, you can do a clockwise turn, turns the bevel up, and then it can more easily advance. I've heard people troubleshoot like that as well.
But you want to make sure you're getting that stylet out of there, because I've seen people like literally poke right through the trachea and do trachea.
Yeah, those rigid stylets you can do some serious damage with those things. And so anybody who's using those things, if you don't know the popping technique that Tyler was talking about, you should definitely go try that like 40 or 50 times because that's really important.
Awesome, man. Well, is there anything else we're forgetting?
No. That's it.
Yeah, I think that's good. So guys, go check out the blog. Some really good pictures. And I don't know, the evidence is pretty cool on it. There's a driver study that was done at Hennepin that showed that they optimized their first pass success. Probably going to be some diehard stylet fans out there that just want to trash this episode, and that's fine. You know, do what's most comfortable for you, but God, do everything you can to optimize that first pass success. Don't just wait for the rest you need for the bougie. Use it whenever you can, and try to put all your cards up forward to make sure you get that right away.
Agreed.
All right, guys. Well, thanks for tuning in. We'll see you guys next time, and we'll see you guys next time.
And we'll see you guys next time. Thanks for listening.
And maybe we'll see you next time.
And brought to you by the FOAMfrat EMS refresher.
Brought to you by the phone. Why does that thing keep popping up, Tyler?
That's a really weird glitch with this program. We're gonna need to check that out, dude. People who are listening to the audio only of this are gonna be like, "What in the world is going?" I guess Oh, hey, here's the other thing. This is if you're listening to the audio only, this is your cue to go subscribe to the FOAMfrat YouTube.
Dude, every time I made this one, I was waiting for you to tell a story, you know, like an experience, and I was gonna have this pop up.
Don't say what it is. The people who are listening to audio, we got to force them into.
Yeah, you guys are missing out on it. Go to YouTube and subscribe. All right, bye.